hypertension. You may see it called intracranial hypertension instead of increased intracranial pressure. For protocol, either administering that mannitol Q6-PRN. Remember what is mannitol or osmotrol? It's an osmotic diuretic, so what's it going to do? Pull fluid off of that brain. What are some of our precautions that we have to be careful about with it?
Kidneys.
Yeah. GI, maybe, in a very roundabout way.
INOs.
INOs, definitely. Electrolytes, definitely. What about with administration, what I'm worried about?
Kidney function.
Don't give it too fast. Don't give it too fast, and I'm going to give it through a filtered set. Okay, remember I told you about microcrystals? Okay, sometimes you have to warm it up a little bit because it'll have visible crystals in it. But you give it through a filtered set, either through a filtered needle to withdraw it and push it, or a filtered IV set. Okay? Drain CSF from the interventricular catheter system. Am I going to open that to drain and walk away?
No.
No. 5 or 6 drops, 5 to 10 drops, whatever my physician order says. Because I want to then turn it back to see what my pressure is going to be. I cannot drain and measure at the same time. Administer sedation per protocol. Remember, anxiety, restlessness, fighting against restraints or the ventilator is going to elevate your ICP. So we're going to sedate, sometimes paralyze, to make sure that these patients heal appropriately. Do not paralyze unless you sedate and give pain medication. Ineffective cerebral tissue perfusion. Patient will not experience deterioration in neurostatus. Is going to be our goal. Monitor that level of consciousness and neurostatus. And I'm going to do a neuroassessment as often as it needs to be done based on what my patient's condition is. Every 15 minutes, every 30 minutes, every hour. And yes, I can do a real neuro exam, including cranial nerve function, in less than 5 minutes. It just takes practice. Oxygen is prescribed. Remember, anoxic brains swell. So we want their O2 sat 94 or better. We're going to monitor that vital signs to maintain that CPP greater than 60. And how am I calculating that CPP?
Systolic.
MAP, mean arterial pressure minus intracranial pressure. Okay? Easy ways to push the button on the machine and see what the MAP is. But if you don't do that, you can figure it out. We want normobulimia. But for subarachnoid hemorrhage, we do hyperbulimia. Well, why? I told you that vasospasm is one of the main problems with after subarachnoid hemorrhage. Hypervolemic. We call it the triple H therapy. No, not high, hot, and hell of a lot like the enemas. Okay, it's hypervolemic. And I've blanked on it right now. Hypertensive, hypervolemic, and what you want to see is low hematocrit. So you want to volume expand these patients. Okay, think about a water hose. I know we're all in the South. What we do, instead of putting the nozzle on like we should so that you can turn it off, that whenever you take your water hose and do your flowers and you're going to another flower bed and you don't waste the water, what do? You
Pinch it
kink the hose, okay, and then take it where you want, and then you unkink it. All right, think about stepping on a water hose. Think about that as your vasospasm. If you've only got a little bit of flow in that water hose, you can mash it all the way to the sidewalk. But if you've got that water tanked all the way on, you cannot compress it enough. And that's what we do with subarachnoid hemorrhage patients. We want them hypervolemic because it keeps their vessels from clamping down in that vasospasm. There's at least some blood flow through if they spasm. Okay? Cardiac status, dysrhythmias. We're looking for what specifically? AFib. Invasive monitoring of ICP's TVP, central venous pressure. Or I know in one of my notes it talked about hemodynamic monitoring. Okay, that's the concept we'll talk to you about in 213. But that gives you an idea of cardiac output and ejection fraction. Also, central venous pressure. Medications as prescribed. TPA. And TPA we're going to give for what kind of strokes? Thrombotic or embolic. Okay, never for hemorrhagic. But antiplatelet aggregate medications we're going to give for patients that have a history of what? TIA. Okay, anything that causes a clot. They have embolic strokes. They have thrombotic strokes. They either get antiplatelet aggregates like Plavix or clopidogrel, or they go to the big guns if it's DVTs that have developed somewhere else, or they've got chlorotics that are included. They may do the Xareltros or the Eliquis or, okay? Basically something that's going to keep that blood flowing to that brain. Impaired swallowing. We want to have that patient avoid aspiration and have adequate nutrition. That bedside swallowing exam or speech therapy exam. These are symptoms that could cue you into someone that is having swallowing difficulty. Facial drooping, drooling is always a bad sign, unless it's a baby. Impaired voluntary cough, hoarseness, incomplete mouth closure. Those are the things you need to look for. Drooling in an adult means it's something that they cannot handle their own spit. They can't swallow their own spit. Think about your face when you had dental work and you fall asleep and you spit and you're stuck to the pillow, okay, because you drool, because you don't have complete mouth closure, you don't have facial control, okay? Distraction-free environment during meals. A lot of times they got their TVs on. Because what you will see with those patients is that they get distracted by the television and they either quit eating or they get choked very easily because they're not looking at the size of the food they're putting in their mouth. Fatigue. When you're tired, you choke more easily. Allow them a rest period if physical therapy has just been working with them before you let them eat. Follow those recommendations for thickened liquids, head position techniques to avoid aspiration. Okay? Thickened liquids, is it honey thick or pudding thick or whatever thick it is? I'm going to tell you, thickened coffee looks nasty. And I will tell you, be careful of hot thickened liquids, because if they fall on a patient that has decreased sensation, you can get second-degree burns. because it sticks and doesn't roll off like regular coffee does. That's why whenever you have thickened coffee, it will be a certain temperature whenever it comes up from the cafeteria. It's not hot. No, we don't want you to burn yourself. Teach family members and patients how to follow those instructions. And you, as the nurse, are responsible for making sure that they have that thickening agent in the room. Impaired physical mobility. Our goal is that they participate in rehab to improve their function and ability to perform their ADL. Remember, with this, you're probably going to see a physical therapy consult as well as an occupational therapy consult. OT is more for your ADL type things, dressing, feeding, those types. Whereas physical therapy is strengthening, walking type deal. Assistive devices. An OT PT will have all sorts of things. Balance is likely going to be impaired. And not only with walking, but sitting. If you've got someone that's weak and paralyzed on one side, they typically lean to that side, and if they're not properly belted into that wheelchair, they'll fall. Mobilize as soon as their condition permits. Once these people are stable, you want to get them up and moving. Pneumonia is going to be a bad thing with these folks. Turn in position, support those extremities in the proper position every 2 hours. Remembering that these patients, no knees to chest, because we want to keep that thoracic cavity clear without pressure. Splints, whatever OT has recommended, on and off schedule or 24 hours a day. Know what that order is. Range of motion every 4 hours, if at all possible. And you're looking at me like, yeah, I got 6 patients, and you're going to tell me that I have to do range of motion all 6 of them every 4 hours. Involve your family in their care. They are looking at you, they are hopeless. I don't know what to do to help them. Teach them how to do that range of motion. And they will feel more involved and more satisfied with the case. Acute confusion. What we want is them to demonstrate restoration of cognitive status to baseline. Looking at their mental stat, assess them as needed, gentle, caring communication. I said you were going home tomorrow. It's not gentle communication. Caring, it's not caring. They will ask tons and tons and tons of questions, and you have to be caring in your interactions every time. About the 20th time, that's when you put the sign up. Now, look at your sign. What does it say? Reorient frequently. Person, place, time, and situation. With your patients that have acute stroke, acute head injury, we want to reorient them frequently, as opposed to our dementia patients. Patients with dementia, as soon as it goes in their head, it goes out. Your 98-year-old dementia patient asks when their mom is coming. You don't say, honey, your mom is dead, because that's new to them every time they hear it. But remember, you're in the hospital. Remember, I'm your nurse, I'm not your daughter. Teach the family to recognize signs of early confusion and seek help, because that is a change, early confusion is a change in mental status. Okay? Maintain that safe environment. The clutter on the floor needs to be gone. The bed alarms need to be on if they're that impulsive right-sided stroke. Impaired verbal communication. We've talked about this a little bit. Speech therapy. Picture boards. You need to give them time to respond. Short, simple statements. Face them and speak slowly. Now, you do not want to exaggerate your speech. Number one, they'll look at you like, who is this crazy person? And you don't need to yell! Because they're not deaf. They just don't process. A lot of people, you'll find yourself doing it. I swear you will. You'll speak up like you do with your hard of hearing lines. But you don't need to. They can hear. They just don't understand. Allow those family members to get permission to speak for themselves. Because that is the only way that they're going to learn how to communicate. Unilateral neglect. What you want to do is set up your environment on their unaffected side. Implement fall prevention. Reminders that they need to look at that side. Remember I told you about the plate. Sometimes you need to turn it around so they'll remember to eat on the other side. Basically, one of the things we do in rehab is teach them to bathe the affected side first so they don't forget it. They need to be aware of that behavior and modify their environment. Impaired urinary elimination. Okay, remember I talked to you about toilet training, those frontal lobes, voluntary control of bowel and bladder. Look for frequency incontinence and voiding in small amounts. For two reasons. Frequency incontinence in small amounts means they may not be emptying their bladder completely and they're having overflow incontinence. Okay? With these folks, just like you do with kids, you take them to the bathroom every 2 hours. And you teach your nursing assistants or your family members when they go home until they're continent of urine. They need to be asked. Instead of, do you need to go to the bathroom? The question is, okay, let's get up and go to the bathroom and sit on the pot. Because a lot of times it will trigger voiding and they will be continent. And they're a whole lot less embarrassed than that than you having to clean them up in bed. Check for residual urine after voiding. Fluids of at least 2,000 mils a day unless contraindicated. And this may be your patient with heart failure. It's on fluid restriction for that heart failure. Kegel exercises. And I know Ms. Beaver has covered it, so I don't have to do it. You know, one of the students, one time during his graduation speech, talked about Ms. Beaver's Kegel exercises, and he was standing there at the podium and said, and I'm doing them right now. The whole class just died laughing. Caregiver role strain. And we're not talking about the nurse, though the nurse can be under role strain. But we're talking about family members. Watch for signs of depression, deterioration, physical health in that caregiver. If this family is staying with them 24/7, they're going to wear out. They need to go home and get some sleep, or at least take a shower. See if there's some other support. You know, I don't feel comfortable leaving my family members alone in the hospital, even though my mother is pretty much with it, but she doesn't understand the lingo. The mother, what did the doctor say? Well, he said something about my heart. I said, mother. And so I said, head call. So we talk, and I understand what's going on, but, you know, sometimes you get things second or third hand, and it's like playing that gossip story, and you get something at the end that's nothing like what it said. Impact of that here on their emotional health. How are you doing? Is there anything that I can do to help you right now? They need to talk about their feelings, their concerns, their uncertainties and fears. If this loved one was the major breadwinner in the house, and the wife has been at home taking care of kids, or vice versa, the wife is the major breadwinner, and husband has been the house husband, or Mr. Mom, or whatever you want to call it. I have a friend that does that. His wife is an anesthesiologist. He says she makes 6 times what I do. I can take care of 4 kids. What do you know? So he's the one that shows up for the PTA. But anyways, if that is the major breadwinner, get them tuned into social work, because they're going to need some kind of support. Whether they need to apply for Medicaid or long-term disability or something. There's still rent due, there's still electric bills due, water bills, insurance, and the whole 9 yards. So they need to start planning for long-term instead of just the here and now. Help them problem solve to meet what those needs are. Are you in a better place here at the hospital, or would you be better served at home taking care of your kids, or at work because you've got someone taking care of your kids? So caregiver role strength is going to be a major problem. All right, any questions? Like I said, if you can treat their ICP, their care is pretty much going to be the same no matter what the injury is. But like I said, there's a lot of commonalities. All right, I'm going to pass these quizzes out, and I'll let you take them. If you want to stay, you're free to go if you want to. But I'll let you take them, and